Hello, we are live on another. I need to come up with a name for this show, to be perfectly honest. Right now, it's just Tom's live Facebook chat fun time.
That's a pretty good name.
Yeah, maybe Tom's Facebook live chat fun time. Yeah, I'll make sure I remember that one.
Yeah.
So thanks so much. I have a very, very special guest today, Dr. Ewan Goligher, who to me, I feel like maybe it's just my nerdiness, but I feel needs no introduction. But for many of you that may actually be watching this, perhaps he does need an introduction. So just so that I do him complete justice, I will allow him to introduce himself. So Ewan, please tell us about, where you studied, where you're from, and where you are now in your career.
Sure. Thanks, Tom. Thanks for having me on. I think you're the celebrity in the respiratory ventilation world, so it's really a pleasure to come on this show with you. So I studied undergraduate and medical school at UBC. Grew up in the Vancouver area, and then moved to Toronto for residency and then critical care training. And then after I finished all that, I was really interested in pursuing research in mechanical ventilation. So I did a PhD in physiology at the University of Toronto, and I have a faculty position here now as assistant professor of medicine. And I work at the great Toronto General Hospital in the ECMO Center, and looking after all kinds of patients with severe respiratory failure.
Excellent. And for those who aren't from Ontario, TGH has the highest number of ventilated COVID-19 patients at the moment, somewhat because they are an ECMO center, so they get a lot of referrals. I imagine that many of your patients aren't actually patients that came in through your emerge department directly. They were probably transferred, I'm guessing.
Yeah, the vast majority really come to us from other centers. Yeah.
Yeah. And about 2 weeks ago, I was fascinated because I'm now working part-time in Kingston at Kingston General Hospital, and we were the second highest ventilated COVID-19 patients in the ICU. We had 30 ventilated COVID-19 patients at one time. Again, also sent to us just due to capacity issues within Toronto. But I remember I look at the Critical Care Services Ontario list, and I look through it all, my old stomping grounds, because I used to work at TGH. I worked at St. Mike's, so I look at St. Joe's and Hamilton. So I'm looking through all the numbers, and I went, wow, TGH is at 38. And I looked down, I'm like, yeah, we're at 30, and I'm looking for anyone else in between. I'm like, yeah, we're in second place. Not that this is an award you want to win. This is not something you want to win, but
Yeah.
it was just interesting that I move hours away from Toronto, and I just keep getting sucked back in.
Yeah,
so.
the patients are following you, Tom.
Exactly. Yeah. So
Yeah.
people were joking that, did they hear you were out here? They were just going to send all these ARDS patients out to where Tom works. I'm like, I don't think they heard, because I'm only part-time. So that's not a very good excuse, but it's a good group in Kingston. So we've been handling it well. So I think the last shift I was on, we still had about 24 vented. So slowly
Well,
going.
I think it really highlights the way that critical care is a team sport.
Absolutely.
And it's really been amazing to see the way that clinicians, whether it's RTs, MDs, RNs, have pulled together in an amazing way.
Yeah.
In the last weeks and months, it's really been a huge collaborative effort. I think everybody's pretty tired.
Yeah.
But I think in a way we can also be very proud of what we've all accomplished.
Yeah, I think if anything, it's really, some people, so I graduated the year of SARS. So I graduated and started working at Toronto General Hospital, and we had SARS patients there, SARS-CoV-1.
Wow.
So that was my first year as an RT. It's like, happy graduation. You're in the midst of we don't know what this is about to be. Now SARS seems like it was like it's like the laughing stock of coronavirus. It's like there was just over 8,000 cases worldwide and like 700 deaths. We had cases in Toronto. We had outbreaks at TGH. But yeah, it was, when I think back, I'm like, that was nothing compared to now. And I used to think that prepared us for this. And in some ways it did. In some ways we had a stockpile of ventilators and stuff. Like we learned from that fear. But we hadn't had to do the things that we've had to do in this pandemic, particularly in the third wave. I mean, this last wave was really when we started getting patients sent to us in the second wave, but I think we got 6 or 7. Like it wasn't that crazy, but the third one, it's insane. So I want to just let everyone know that's watching, if you have any questions for Dr. Goligher, please post them in the chat, and we'll try to answer as many as possible. I'm going to review some of the reasons why I have. I'm gonna call Dr. Goligher Ewan, just because.
Please, yeah. By the way, absolutely.
Yeah,
Dr. Goligher is unacceptable.
I feel strange when because I consider you a friend as well. So
of course,
I always want to respect the titles, but at the same time, I'm like, when I see him, I never refer to him as doctor. I just say, it was interesting when I worked with Laurent as well. Everyone I work with, they're all, most of them are foreign trained. They come here, they do like their clinical fellowship with research with Laurent, and they all call him professor when he walks in. And I was just always calling him Laurent. And it was, I'm like, am I doing something wrong here? Like but I felt more collegial with him. Like, we'd have many chats. I didn't feel like he was my professor. So I didn't, I felt like I was doing whatever work he asked me to do, but it was different. I think a different relationship. They're there for their, PhD studies and master's studies. So he's very much a professor to them. Although I could argue he's a professor to many of us, but. Oh yeah.
Well, he's a very gracious man. So I think once people get to know him, I think they feel very comfortable.
Yes. Yeah. And I quickly became he made me feel very comfortable. And actually, just before I get into that, I've never worked clinically with Ewan, but I feel like I have in some remote way. Ewan and I had
kindred spirits.
Exactly. Yeah. So Ewan and I had participated in many lab meetings together. We were having very regular mechanisms of acute lung injury meetings, otherwise known as MOI meetings. And then we have the, which is that what changed the Brian Kavanaugh rounds now? Or was that another one? Because we had a number of them.
Physiology rounds is now called Kavanaugh physiology rounds. Yeah.
Correct. Yeah. So I would see Ewan regularly, and anytime that he gave a talk, I was usually one of the people that would come up afterwards and ask him some random nerdy question.
Tough questions.
And not normally easy questions, but generally questions that you typically responded with like interest to answer. You're like, that's a good question. So yeah, I've always had a really nice relationship with Ewan. I've learned a lot from him, and I've utilized emailing him a number of times when things were confusing. I remember when I read your paper with Michel Bertoni on the POC. I'm like, hey, check this out. I made an online calculator for you. Like, that's my level of nerdiness. And like, I thought it was so cool that I should have an easy way for people to calculate it online. And you were like, whoa, like, because you didn't ask me to do it. That was the funny thing. I just said, hey, by the way, I did this calculator. Check it out. And you're like,
usually useful. I think we put that in that paper, didn't we?
I think you did. Yeah. So it was the preprint. Yeah. I think I'd seen it was published online ahead of print, where it always looks horrible. It's not formatted yet. And then I made the calculator, and then you're like, we're going to add this to the paper. Yeah. So yeah, there is a link to it.
That was huge.
So some of the things that I want to highlight that really, the reason why I got you on here, and the title of the presentation is Monitoring Patient Effort with Dr. Ewan Goligher, because this was a lot of the basis of your PhD was on the diaphragm, correct?
Yeah, that's right.
So go ahead.
Yeah, we're really interested in characterizing what happens to the diaphragm in real patients in the clinical setting. Before my PhD work, ventilator-induced diaphragm dysfunction was sort of a laboratory phenomenon that had been well characterized in animals, but not really much in humans. So
yeah, we had very little data in humans. I mean, there's the muscle fiber, like in the brain dead patients, like the classic New England Journal of paper, but this is really the New England Journal of Medicine paper. But that's like the bulk of what I understood. Basically, I think what we understood prior to a lot of the work that you've done, and I don't want to give you exclusive credit to the term or the idea of patient self-inflicted lung injury, but a lot of this has to do with the work of the diaphragm. And so, but prior to that, I think as respiratory therapists, we were under the impression that we need to start spontaneous breathing as soon as possible, which is not a bad concept in theory. But I think what you've uncovered a lot with your work is that not all spontaneous effort is created equally. So we need to understand where patient effort can actually become more injurious to the patient and their course of mechanical ventilation. And I think prior to a lot of the work, we were just this constant guilt thing, like we got to get them breathing spontaneous, we got to get them breathing spontaneous. And then when we do, we just let them go. And then a week later they fail again and we don't understand why. And, we're looking for sources of infection, and which could be the case, but sometimes patients are failing 1 week later and they can't find a source of infection. They don't understand why the patients are failing. And then we realize that they could be causing their own inflammatory response to how they're breathing. So in terms of, I can go over all of the work that you've been doing, but I think what's nice is you have 2 papers that really summarize a lot of the work you're doing. One of them is this one, which is lung and diaphragm protective ventilation, which was published in the Blue. This is the Blue Journal, correct? Yes.
Yeah.
In 2020, was it? I think
that was most last recent. Fall.
Yeah. And so you actually published 2 that I'm going to talk about that I think really encompass a lot of the work that you've been doing, but also with other colleagues. And what's interesting about this paper is that you basically are a group of expert panelists that got together to determine which elements of, for example, lung protection are most important, which elements of diaphragm protection are most important. And then you weighed in on things like which one should be prioritized. And I think the consensus was lung protection should be prioritized over diaphragm protection. However, how they interplay is very important. And clearly we need more data, which you're working on, and I'll give you an opportunity to highlight some of the work that you're doing now. But this was a very thorough paper. I found it very intriguing because, you get these responses from the group where they have the distribution of ratings and then the percent of the number of panelists, and there was 31 in total, the percent of them that agree with the statement or that express support for that statement. And I think this is a really good read for respiratory therapists if they really want to sit down and really analyze what all of this is about, because I think we hear the term lung protective ventilation all the time, but how that plays into spontaneous breathing is really well displayed in this paper. And then you get a sense of what the experts in the field actually think about all of this stuff. So I found this one to be very fascinating, really.
And where we all disagreed. That was one of the fun things about that table is that I enjoyed as much as a way to highlight where people disagreed as much as where they agreed.
Yeah. Like, for example, down here with sedation, like I've heard you mention many times that I know your stance on propofol is that it's a much easier drug to help manage drive than, for example, opioid. If I'm paraphrasing that easily enough, but you can definitely see there's not consensus for sure. Yeah. And that one stands out right there as I scroll. That one's probably the lowest in terms of support with this statement. But I read that statement and I'm like, I've heard Ewan say that, and I tended to. I understood, and I think I asked you why, and you explained it, and I said, "Oh, that makes sense to me." But you can see it's not just because one person thinks something; it doesn't mean that everyone is considered this or considers the same thing. So, also some very fantastic graphs. I've given talks where I've had this picture on many slides, and I think I've even used a graph from the next slide I'm going to show as well. But then when you get down to it, you actually definitions and terminology, like again, for fresh respiratory therapists or students, this is a fantastic article because you have definitions of all the key things that all of these papers discuss. So atalic trauma, we tend to learn that kind of stuff in school, barotrauma, biotrauma, classic papers from Art Slutsky describing these with very beautiful graphics in the New England Journal of Medicine. But then when we get down to eccentric myotrauma, these are things that are not, again, we didn't learn about this stuff in school. We know lung protective ventilation, over assistance myotrauma. Again, we just consider this as diaphragm atrophy, but giving it a new, again, I like this idea, and I know that you've talked about this, giving it a definition of myotrauma, because it's not just atrophy. It's like we're causing an injury to a tissue. So it's not just we're just ignoring it. Like there is a harm associated with this. So I think using the word myotrauma actually sort of highlights that.
And when I came up with the word myotrauma, the main reason I liked it was because people already use words like atalic trauma and volutrauma and biotrauma to understand that the way you set the ventilator can injure the lung.
Yeah,
and
absolutely.
So basically, myotrauma was meant to be the parallel. Well, the way that we set the ventilator can injure the muscle.
Yeah.
In a number of different ways. But that was basically the idea. It was like, I just thought it was a cool kind of way of adding additional language for us clinicians at the bedside.
I think I forgot that fact. You coined that term.
Like,
I don't remember seeing it prior to you publishing that, but yeah,
Yeah, there's a
is it
bit of a
safe to
story
say
there,
that
actually.
term is it safe to say that you made up that term? Not made it up, but you
Yeah,
brought it to
yeah,
the highlight?
yes. I mean, if you do a literature search on myotrauma, you'll see references to it prior to some of the papers that we wrote. But the first paper that I put it in was the paper describing the evolution of diaphragm thickness that we
Right.
published in the Blue in 2015.
Yep.
And actually, in the original submitted manuscript, myotrauma was mentioned in the text of the manuscript, and one or two of the reviewers didn't like the word, so we had to take it out just to pacify them. But when you first submit a manuscript, you put in keywords, and I put myotrauma in as a keyword on that
And
paper,
it
and
wasn't caught?
completely forgot about it. Didn't even think of taking it out. So when we published the paper, I looked at the keywords and like myotrauma is right there.
Oh, that's
So
hilarious.
anyways, yeah, there's a funny little story there. But
And
yeah, we like that word just because it gives us kind of useful, simple clinical language. It's a lot easier than saying ventilator-induced diaphragm dysfunction.
yes, I remember the first time I heard this term, I think might have been listening to a talk you gave. And yeah, I'm just like vid. I'm like, okay, so now we got villi, we've got vid, we've got,
Yeah,
and then P silly was that was another one. Another one. I'm like, oh man, all of these
yeah,
terms. But
yeah.
yeah, I would agree with that one as well. So yeah, I really suggest. Now, I don't know if this paper is open access. What I normally do is I'm going to quickly double check. That is this one here. I'm just gonna double check because sometimes it's not. Okay, so it is not open access, but if I just secretly say if some of my viewers want to see the paper, I may show it to them. So just send me a message and I might show it to you.
Yeah,
Um,
or email me and I'll send it to you. It's no
yeah,
problem.
so I think what I might do is, because this is a live broadcast with the author, what I might do is actually download this paper, and I'm going to upload it right now to a share service. Just open it up quickly. Restarted my computer and it closed. Okay, there we go. I'm just going to put it in the chat for those that are listening. There we go. All right, here's a copy to that paper. Just don't tell anybody. I know this will be live on every platform that, anyways, I haven't gotten in trouble yet for sharing papers. Okay, so that's one paper. And then this was another one published in the same year. When I saw this one, I thought, isn't this similar to what they just published? But then when you realize the whole expert panel thing, it's a much deeper paper, the previous one. I think it's much more in terms of what you get out of it. This one I find fantastic because it's a narrative review. And I think that as a going forward reference for respiratory therapists, this is a fantastic Cole's notes, basically, that just describes these things rather than seeing if people agree or not. This is kind of like an expert opinion. Again, you being first author, but this is your view of this concept of clinical strategies for how to handle lung and diaphragm protective ventilation. Anything you want to say about this paper and the process of publishing it?
Yeah, I mean this was, like you said, not formal. There was no kind of formal process to put together this paper. It's more of an expert opinion piece. But I think what's nice about this paper is it's more practical.
Yeah.
It especially the figures that are further down in the paper is sort of just a practical approach to how do you get patients breathing spontaneously? What do if you want to optimize respiratory effort, what kinds of factors do you adjust and target? So I think it's a nice overview and a nice kind of practical description of what lung and diaphragm protective ventilation might look like. This paper basically describes the kinds of clinical algorithms that we're testing now in trials.
Yeah. And is this the
And
landmark trial?
yeah,
Okay, I'm
exactly.
going to ask you about that trial in just a moment. So as well.
Sure.
So yeah, I think this is another really good paper for RTs. A lot of really good descriptions. advantages to each of these therapies. So we have looking at airway driving pressure, pressure and flow waveforms, the P0.1, which I've mentioned many times in the last year on my broadcast, the POC, which is the single breath occlusion or the whole breath occlusion. And then you have esophageal pressure, transpulmonary pressure, transdiaphragmatic pressure, diaphragm inspiratory thickening fraction, and diaphragm electrical activity. And again, even pointing out things like you need specific equipment. So requires equipment and training, requires equipment and training. So really, if you're in a center that doesn't have a lot of the tools, you're going to find something on this page that you can utilize clinically to help understand the impact of spontaneous breathing on lung protection. So again, another fantastic paper. This is the kind of stuff that, again, I think every respiratory therapist needs to read and understand, because we are manipulating the ventilator and we monitor the patients more than the physicians do. I mean, if you think about it, you guys are doing rounds, you're seeing that patient at that bedside maybe once that day, depending on how busy you are. Whereas the RTs are doing rounds every 3, 4, 2 hours, depending on, what your rounds are, or whether you get called to the bedside. So we're supposed to be the eyes and ears, we're the feet on the ground, we're the soldiers. And if we don't understand this stuff, then what's the point? If you understand this stuff, but the clinicians don't, then that's a problem. Now, I would argue that many clinicians, meaning physicians, aren't aware of all of this stuff, or may not be as interested in this as perhaps the groups in Toronto. Like, I know St. Mike's is interested in it for sure, because I worked there and we were looking at this stuff nonstop. TGH, obviously, Toronto Western, I'm assuming that they are at least interested. They may not be as active as TGH. I don't know. They're part of the same health system, but I know you guys are quite different in terms of your patient populations.
The patient populations are a bit different, but I think awareness and appreciation for these issues is spreading.
Yeah, I know transpulmonary pressure was on the rise a couple of years ago. They had a practice leader who eventually left, Sean Marshall. He was there, and I know he was really trying to roll it out. But yeah, there's a lot of interest in Toronto because a lot of this work is coming out of Toronto, so it's really exciting. That's why I wore my Toronto Blue Jays hat for this live broadcast. Mind you, I wear it regularly, but my normal hat is my Hurley hat that I wear for my broadcast, but I had to put the
Oh, really?
on.
Okay, nice. Yeah. Nice.
So this is also a really nice graph here. Do you want to talk about this a little bit? Because I have been mentioning this. So first thing I'll point out that some hospitals right now are in shortage of some of these drugs. So unfortunately, some of these strategies may not be feasible. Like, I saw an increase in opioids being used when there's been shortages of propofol, which unfortunately becomes a complicated problem when patients start breathing. So can you just describe some of these drugs and sort of their mechanisms and why they're important for respiratory drive?
Yeah, thanks, Tom. So it's interesting, and preface it by saying, in general, I think it's become apparent that the traditional way of siloing sedation off to the nurses and ventilation off to the RTs is not going to work so well once you start being concerned with how the patient's breathing, because both of them have a big impact and they really interact with each other.
I agree.
So that's a big challenge that we're going to have to surmount, is how do we integrate these things? So it's really important for RTs to have an appreciation for what sedation does to breathing. So I'm so glad you're bringing this up. I mean, basically, what's the crucial thing is that different classes of sedatives have, in general, different effects on the pattern of respiration. So whereas propofol and benzodiazepines tend to reduce tidal volume more than they reduce respiratory rate, opioids will tend to reduce respiratory rate without affecting tidal volume very much at all, and may even increase tidal volume.
Yeah, I was going to say, I usually call it morphine breathing when they're taking, when they're breathing 10 breaths per minute and it's like a liter. I'm like, that's morphine breathing right there. Yeah.
Exactly. And so, from the standpoint of lung protection, we all know what we prefer, which is a smaller tidal volume and a higher rate in general. And so, this is why we have to be careful about how these drugs affect breathing. The other thing too is that if you have a sedative that depresses the patient's intrinsic respiratory rate, say their normal respiratory rate is say 12 to 15, and they're on an opioid infusion and their rate is depressed down to 5 or 6, as long as the ventilator's set rate is higher than the patient's intrinsic respiratory rate, that patient's just going to happily ride the ventilator.
Yeah.
So it's harder to get a patient breathing spontaneously if they have a depressed intrinsic respiratory rate. So, one of the things that we're working on are developing strategies to test in trials where we try and get patients off opioids or on minimal levels of opioids. Of course, thinking about other things like pain at the same time,
Of course, yeah.
so that you get the patient's respiratory rate up, so that that it's not so difficult to get them triggering the ventilator, so that they start breathing sooner, with a view of protecting the diaphragm from atrophy.
Yeah. And I just shared this paper as well, because that was one of the comments. And someone put a link to the narrative review. So I just posted the actual paper. Let me know if it goes, if someone in the chat can let me know if it goes through, because it says an error occurred. It looks like it went through, but then it says an error occurred. Wait a moment and try again. So just let me know if the link went through on Facebook. So yeah, I actually, one of the interesting things about the drug aspect of things, I remember I did a talk on weaning a few years ago, and I discussed, of course, Smart Care, which is an automated weaning mode. It's available on Drager ventilators. And when you look at the data, there was a study. So the study that was done in Canada, actually, most of the RTs that participated in that study, I remember asking them, do you guys know the results of that study? And they all said no. No, like nobody knew what the results of that study was. And the results were actually that Smart Care weaned on average got people off the ventilator 1 day faster than a protocolized respiratory therapist. And what's interesting is when Smart Care was studied in Australia, they did not have that issue. But when you look at the practice in Australia, the nurses are the ones running the ventilators and the sedation. So exactly what you said, it's going to become more challenging. Not that we're suggesting giving ventilation over to nurses. I'm sure they'd be happy not to. I don't know any nurse that wants to start running a ventilator also. But perhaps there needs to be some strategy, or at least more in-depth communication between respiratory therapists and nurses. I know I had an incident about 3 weeks. I don't want to say an incident, because actually it was a positive incident. But I remember I went to the bedside. I had a patient who was post-COVID weaning. Well, he was still infectious. He was still in isolation, but we were trying to wake him up. And he was on sedatives and paralyzed at the bedside. And I came by for my rounds, and the nurse said, I turned off his paralytic, and he started fighting the ventilator, so I turned it back on. And I said, do you know what was what was fighting? He's like, I don't know. He just looked uncomfortable. And I said, well, I can probably fix that. Can we try it again? I said, can you turn it off while I'm here? And I think that's one of the things I think, when we do these sedation vacations or whatever someone's policy is to try and assess someone, I honestly feel that for complicated patients that don't, some patients will just wake up and start triggering above the ventilator and you have no issues. But for patients that wake up and then the nurse's impression of that patient is that they're not comfortable, I think it should be done with a respiratory therapist at the bedside to counteract that discomfort and get them on a more comfortable setting. And so we did that. We turned off the paralysis. The patient was on a lot of opioids. And I asked her, how much leeway do you have in weaning these drugs? Because he was on propofol, midaz, and hydromorphone or fentanyl. I can't remember which one of the opioids, but I basically said, can you turn all of those like to half? I said, is he having pain? I said, can we just turn like the hydromorphone off for a moment, and see if he starts to grimace, then give him a little bit. I said, but all of this is really is going to affect him waking up nicely. And she did. She just, it was funny because I felt very, very privileged that day that I had a nurse listening to my advice on drug management, but I'm like, can we turn that down and that down and that down? I said, leave a bit of propofol. That's okay. And the patient started breathing.
You're just so darn persuasive, Tom.
Yes, I was being very nice and very charming. I was not, it wasn't, I was being we were being very collegial, and she was interested. I was explaining to her why. I was actually explaining how opioids affect the drive. Again, all the information that I just shared on this paper, this is the kind of information I was actually telling her at the bedside. And it was enough for her to say, okay, cool, let's try it. And I think that's important as clinicians, that if we understand, if we just go in there and say, can you wean the sedation? And they're like, which one, why, this and that. I gave, some background as to why I was thinking about the morphine or the fentanyl or whatever they were on. But anyways, patient woke up. I had them on pressure support within a half an hour. I was in the room for quite a while, but I waited until some of this stuff, till it had enough of a drive to take over the ventilator, and he maintained on pressure support, and we were able to transition him off. So I wonder how many times that happens, where there's an attempt to wake up, but there's no one there to manipulate the ventilator. And then it's just a cycle. They just turn it back on because they don't know what to do. So yeah, I think this is, the next step, I think, in managing these patients is really communication between everyone.
Yeah.
I'm gonna now, I want you to discuss the landmark trial, because from my understanding, so I missed, there was a, I don't know if it was the mechanisms of acute lung injury meeting recently, or I think Jose basically discussed the land. So I had every intention of going to that, and then something came up and I couldn't go, and I was actually really bummed out, because so when I talked to Bouchan, I said, what did they say? What's going on with the landmark? And Bouchan kind of, I think he said that feasibility is good. They're going to move forward with a clinical trial. But I'm not sure. I'm sure you can give me a much better synopsis of where you're at and what you found. But first off, explain what the landmark trial is, because I think this is an extremely important trial for RTs.
Sure. So landmark is basically an effort to try and put these ideas into action at the bedside. So landmark stands for lung and diaphragm protective ventilation by means of assessing respiratory work. Anytime you're designing a trial, you always have to have a cool name.
Yeah,
So
I need to find one for my Facebook Live page too. It's just complicated. It's very complicated.
So anyways, it's a bit of an awkward name, but you're just trying to force it into a cool word. So that's where it comes from. But basically the question is, in patients with acute hypoxemic respiratory failure, can we achieve lung and diaphragm protective ventilation conditions? This is the condition where the patient's using their diaphragm, but the work of breathing is not excessive, the respiratory effort's not excessive, and at the same time, the lung is not over-distended either by the ventilator or by the patient. And so the question in the trial was, A, can we achieve those conditions? And B, how does titrating PEEP affect our ability to achieve lung and diaphragm protective conditions? Because there was some previous suggestion in the literature that using a higher PEEP would actually promote these targets. So we wanted to test that at the bedside. So my superstar postdoctoral research fellow, Jose Dianti, is the one who's
fantastic,
running the trial, and really has done amazing work. It's a complicated protocol, and we're going to be writing papers out of these data for years to come, because it's such a rich data set.
That's awesome.
Yeah. So do you want me to basically get into the mechanics of what we did in the trial, or
please? Yeah, that'd be fantastic. Yeah.
Yeah, so we enrolled a total of 30 patients, and we enrolled them as early as possible after intubation. And basically, as soon as the clinical team didn't think that the patient needed to be paralyzed anymore, there was no medical indication for passive ventilation, we initiated the protocol. And the first step was basically a sedation adjustment phase, where we minimized opioids, reduced sedation, adjusted the ventilator, just to get the patient triggering the ventilator continuously.
I feel like my patient was in the landmark trial the other week.
Yeah, exactly. Yeah, and I want to emphasize, we're really trying to do this not in the weaning phase, but early on. The overarching goal being to protect the diaphragm from atrophy, while also maintaining usual lung protective ventilation. And so these patients are pretty sick. Actually, almost all of them had moderate or more severe ARDS. The mean PF ratio was actually 88. These were very sick patients we were trying to do this in. About half of them were on ECMO. And
what was the oxygen requirement? Did you have like an FiO2 requirement prior to spontaneous breathing? I guess if they're on ECMO, it wouldn't matter, but.
No, to be enrolled in the trial, you had to have a PF below 300, but it's just the kind of patients we have at the general that most of them are quite hypoxemic. And like I said, we wanted to do this very early. So I'd say most of the patients were on 70 or 80% at least.
Wow. Okay.
When we got to do it. So, and then once the patient's continuously triggering the ventilator, then we did the second phase, which is where basically patients were randomized to go onto either a higher or a lower PEEP, and then they crossed over to the opposite level of PEEP. And at each PEEP level, we have this algorithm where we would progressively adjust ventilator support and sedation, with the goal of trying to get the patient's respiratory effort within target, while also ensuring that the degree of lung stress is in target for lung protection, and making sure that the patient is adequately ventilated based on a pH target. So I like to say we're turning ventilation from a two-dimensional problem where you're thinking about the lung and you're thinking about adequate ventilation into a three-dimensional problem where now it's the lung, it's ventilation, and it's diaphragm and respiratory effort.
Yeah, we all think of gas exchange in the lungs, and then we just ignore what the diaphragm is doing usually.
Exactly. And the interesting thing is when you ignore what the diaphragm is doing, things don't go badly. So what we found in the study is that the first thing is that at the time of enrollment, nobody was on target out of the 30 patients. That's probably because most of the patients were breathing at all. But even once we got them continuously triggering the ventilator, what happened was they went from very low effort to very high effort. And so then the actual titration phase became a question of, can we reduce their effort down to target with adjusting the ventilator and adjusting the sedation. And we found that in most of the patients, we were able to get to target. And what was interesting is that actually a lot easier to get to target in patients on ECMO than it is in patients not on ECMO, because the drive to breathe and the CO2 load is much easier
the gas
to
exchange
control
is
under
optimized.
ECMO. Obviously under ECMO. So it's
were there any indicators of like patients that were like nearly impossible to control, or not control, but even to adjust? Was there like any factors that were associated with like basically the problem child?
Yeah, I think so. That is what Jose is going to be looking at as he analyzes the data further. But I think on a first look, it's clear that patients with worse mechanics, higher elastance, are harder to get into target.
Yeah,
and that's just what you'd expect because they've got less lung volume to work with.
Yeah, there's even data from Georgopoulos. He's big in using PAV, and I remember him commenting on like if the compliance was, I think he said if it's less than 20, he's like, forget about it. Like they just can't have a normal drive. So compliance has played a huge role. So there is a question here, and I think maybe instead of just answering this one, we'll also answer how are you measuring the lung stress, because obviously the effort is one part, but then the potential for injury is another.
Sure. So we're measuring for the purpose of this study, we're measuring effort with an esophageal balloon, which is the gold standard technique. So we look at the esophageal pressure swing as a surrogate to quantify effort. And then to measure lung stress, we look at the transpulmonary pressure swing. So transpulmonary pressure, as you all know, is the difference between airway pressure and esophageal pressure, which is a surrogate for pleural pressure. You've got a beautiful figure for us, Tom. Do you want me to walk through these tracings?
Please do. Yeah.
Okay, sure. So here we've got tracings of flow and airway pressure, which you have pretty much all the time on the ventilator. And then if you have a balloon in place, you get esophageal pressure as well. And you can see that during assisted ventilation, with every breath, there's a negative swing in esophageal pressure, even while there's a positive swing in airway pressure. And of course, what that means is now the lung is getting distended from two places. It's getting distended from the vent, and it's getting distended by the respiratory muscles. And the total lung distension is quantified by the transpulmonary pressure gradient, which is the difference between airway and esophageal pressure.
Yeah, so and for those that don't, and for those that aren't aware, if someone is passive, this bump actually goes up with the airway pressure. So again, you'll have very different transpulmonary pressure, which is why it's important for us to understand this as respiratory therapists, that someone breathing may actually be generating quite injurious pressures. So please go on. I just wanted to point that out, that usually this goes up, but when it goes down, and if you're in a pressure targeted mode like you are here, you're on pressure control, someone starts breathing, your transpulmonary pressure instantly changes to something higher.
Exactly. That's such a great point, Tom. And it's interesting because our friend Giacomo Bellani likes to call this an iceberg phenomenon. Yes. Most of the iceberg is below the water and you can't see it.
Yep.
And if you took that patient and applied that tidal volume, you might get a plateau pressure, in the high 30s or 40s. And because most of the pressure is coming from the respiratory muscles, the airway pressures don't look that high. And so you're not so concerned. And so this is why we really need to switch from a paradigm where we primarily assess lung protection in terms of tidal volume to assessing lung protection in terms of the actual lung distending pressure, which is really what drives ventilator-induced lung
Yeah.
injury.
And which, as you mentioned, is an iceberg on supported ventilation. I mean, even if this is pressure control, the point is what the patient's doing is this iceberg phenomenon. It's actually a very good graphic. When I've seen him talk before too, and he's got the picture of the iceberg, and he's like, the effort we think is happening, and then like what's really happening below.
Yeah.
And it's a perfect analogy for what's happening. And then, so are you comparing then, so you're obviously using the gold standard, which would make sense for a clinical trial, but are you, I mean, I'm assuming you're also collecting this data with the single breath occlusion?
Yeah, we measure POC. So POC is the swing in airway pressure that you measure during an expiratory occlusion that you apply to the patient for the duration of a single breath. And the idea here is that if you occlude the airway, it unmasks the depth of the patient's effort, because now you can see this negative swing.
Yeah.
And, a kind of basic physiological point that you need to appreciate is that anytime you make an effort against an occluded airway, you're going to generate more pressure than when the airway is open. And that's just because it's an isometric contraction rather than an isotonic contraction. It's like going back to high school kinesiology here.
Yeah.
So this is why the POC, the esophageal pressure swing during the POC looks bigger than before. But interestingly, actually, if you scroll all the way down to the bottom of that figure, you can see that the diaphragm electrical activity is exactly the same during the occluded breath. So the maneuver doesn't actually change when you do it randomly and unexpectedly, the patient's effort doesn't change at all on that first breath, because respiration is so rhythmic. So that way the POC becomes a kind of useful, non-invasive technique for assessing respiratory effort when you don't have a balloon in place.
Yeah, no, I've found it very, very useful to look at. And in fact, many people have heard me talk about P0.1, which is the first 100 milliseconds of a breath. And what's interesting is that when you first published this paper, I thought to myself, well, what would this tell me that in terms of like drive or effort, what would this tell me that P0.1 doesn't represent? And the fact is that even if you're not looking at how this predicts excessive PMUS, you can have a patient with high drive that actually has a normal or a low POC just due to diaphragm, again, basically atrophy or injury, or you have a diaphragm that's not functioning the same. So you have high drive, but you're not necessarily causing the potential for injury that you might assume with a high P0.1, which I think is very important now, because I mean, we're seeing patients with P0.1s of 12 and 13 with COVID-19. And interestingly enough, when you do these maneuvers, they're also excessive, but you may find a patient where it's not, and then you can probably treat that patient somewhat differently in terms of whether or not you resedate right away or paralyze right away, because the P0.1 is only one part of the puzzle, and I think this really adds a lot of usefulness if you don't have an esophageal balloon, obviously, which many centers aren't dropping them when patients are breathing spontaneous. Just clinically, most people are dropping them. If they're using them in the acute phase, but not normally in the transitioning phase.
One other interesting way in which POC adds information to P01 that I've noticed a lot now, because we're monitoring both routinely, is that if a patient is auto-triggering, which is actually surprisingly common,
yes,
often the P01 actually will be 1 or 1.5.
Yep.
But if you do a POC, you'll get nothing.
Nothing. Yep.
Because the patient's actually not breathing.
Yep.
So that's.
I used to do so before a POC was a thing. I used to always do expiratory holds just to see if the person was breathing, because you could be in pressure support with perfect gas exchange actually, and your patient has zero drive whatsoever. Actually, I think I had this discussion last week, because I was pointing out that you could have a patient. I had a patient once who was on dialysis, and the dialysis line got kinked or whatever, and the dialysis stopped and the patient went apneic. They were on pressure support. So I get called to the room, the patient's apneic, and I'm like, oh, that's strange. So I put them on a rate, and then while they were in there, they fixed the dialysis machine. I saw them start to trigger again. I'm like, well, this is interesting. So then I look, and very tiny, and some ventilators will auto cycle, so you can't really see the fluctuations in pressure, right? Now, if you could scale that waveform, you'll see the pressures again, it was the dialysis line. It was just the pulsing of the dialysis line
Wow.
was actually enough. So it's when it stopped, the patient stopped breathing, but it was because the dialysis, just where the catheter had to be sitting and the position the patient was in, was actually enough to trigger the ventilator. And I tell people that anytime you have a patient who has trouble triggering a ventilator, like legitimately seems to have trouble, I said, don't play around with your sensitivity. I said, it's going to be another problem. It's going to be delayed cycling. You're giving too much pressure support, too much volume, the too long to exhale. Like there's so many other issues because a ventilator set at 2 liters per minute of flow is so sensitive that a heart can trigger it. And if you think the patient can't trigger it because it's not sensitive enough, you're wrong. And like you said, it's way more common than we think having a patient that auto cycles. So yeah, it's very, very common. But a nice, easy way is just do an expiratory hold of 5 seconds and just see what do they do. If there's no effort, if they've been breathing what seems to be regularly, as soon as you do an expiratory occlusion, you might just see cardiac oscillations, but you won't see an effort. So I want more people to ask questions. Usually there's questions all coming in, but maybe they're intrigued by our conversation more than not. So I wanted to show this graph. So in terms of the algorithm, is your method somewhat similar to what was published in this paper?
For
Landmark,
the Landmark trial. So the algorithm that we test in the Landmark trial is what you actually do if the effort is out of target. And this was more about a monitoring algorithm for regularly reassessing whether the effort is on target or not. And then once you've identified the patient's not on target, well, now how do you decide, do I adjust the sedation? Do I adjust the ventilator? How do you decide what you should adjust? So the
and you're also assessing
Landmark is
you're also assessing PEEP and the response to PEEP as well.
Exactly. Yeah.
So sorry, go ahead.
No.
Oh, I thought you were going to say more. There was another thing that I've noted. So we had a brief discussion before we came on live, like maybe 5 minutes, and I know that when I became an effort nerd. Again, thanks to Ewan, I became a little obsessed with effort. And I was always, when you were talking about this stuff, the trials like Landmark and this work here that you were doing at TGH, I'm just like, can I share my time between St. Mike's and TGH? Like I kind of felt like I was missing some of the really cool stuff. We were doing some funky stuff over at TGH, but I mean, there was some cool stuff going on. Every time we had the meetings, I'm like, oh man, I'm a little bit jealous right now. But one of the things that I've noticed, and I don't know if it's just because we're seeing a whole lot more ARDS, but I feel like there's just this insatiable drive with patients with COVID-19 that are waking up. I find they're persistently hypoxemic, like needing oxygen much longer than I feel normal ARDS would on average. And again, I don't know if it's just, again, it could be just anecdotal that because we're seeing more of it. I just feel like, we have patients, for example, that, we're always in this hurry to wean FiO2, wean FiO2, wean FiO2. And I find that some patients their saturations are acceptable, but their drive is insane. And on a few of these patients, and this is actually part of the Caviards trial, one of the mechanisms, if someone does have a high drive, is actually increase FiO2 to a higher target saturation. And numerous times I've seen patients' rates go from like 40 down into the 20s just by increasing FiO2. So again, I feel like they're persistently hypoxemic and they have insanely high drives. Are you seeing or finding patients with COVID-19 have an excessive drive more so than what you used to see? Because you've been looking at drive for longer than anybody I know.
Yeah. I agree. It's hard to know for sure because
is it just prevalent, like so many ARDS patients?
We're just seeing so many patients. If you go back to Michele's paper where we describe POC, there's some plots in there where we describe the distribution of effort and transpulmonary pressure in the patients in whom we derived the POC measure from. And you'll see actually that the transpulmonary pressure swings and effort levels were way out of acceptable limits on most of those patients. Look at the figure on the left here, the PMUS. You can see on most days patients are on average above what we
Yeah,
think are acceptable limits. And the same with the transpulmonary driving pressure. You see a lot of the time the patients were up. But, I agree in COVID patients, we've seen swings of 30, 40, 50 centimeters of water during spontaneous breathing. But, pretty early on, I think it became recognized that the biology of COVID is a bit different. And I think that the profound endothelialitis that these patients get compared to regular ARDS is probably a big driver. Their dead space is incredibly high.
Yeah.
So that means the ventilatory load is very high, even if their mechanics are not so bad. And I think probably there's lung reflex stimulation that unfortunately is nearly impossible to measure or to demonstrate. But there's no question that these patients have very, very high drive. And actually, to be honest with you, that was one of the reasons I got into heparin research in COVID, was because of this whole issue of endothelial dysfunction, clotting, and how much that was contributing to the respiratory
And
failure.
congrats on the preprint. I looked at it yesterday.
Oh, thank you.
Again, I'm a nerd, so I figure I find this stuff. But it was it yesterday or the day before? I think the preprint became available. And is this the attic? Is that the attic trial? Is that what that's referred to? Is that the fancy word for that one, or
Yeah, well, in fact, it's a multi-platform trial that
remap cap is the
exactly
main thing?
remap
Yeah.
cap, active 4A, and then attack was the Canadian trial that we were leading. So we published the papers are now under review, but we put up a preprint for critically ill patients.
Yeah.
And then yesterday was the hospitalized patients who were not critically ill.
Oh, right. So I think I may have missed the critically ill one, because I saw the hospitalized one, because I was actually talking to an internal medicine guy yesterday who works in Alberta. He's not ICU, but I asked him if he had seen that paper, because he treats people, prior to ICU kind of thing. Where the results of the critically ill one was basically that it wasn't advised to do anything different than just the normal prophylaxis, correct?
Yeah, if anything, that routine therapeutic anticoagulation was actually harmful.
Was a bad idea. Yeah.
In these patients, which, well, I have to say, I thought it would probably work in hospitalized patients to prevent respiratory failure. But at the same time, I really expected it to have a real benefit in critically ill patients because the thrombosis rates were so high. But if anything, there was a signal for harm. But it's pretty cool to see heparin actually preventing the need for intubation.
So for those who aren't aware, he was just discussing the critically ill paper that looked at, again, basically therapeutic heparin to try and deal with some of these clot issues that COVID-19 patients were having. And there was a signal for harm, no benefit to critically ill patients, but they just published the preprint for hospitalized patients. So these are patients that were hospitalized. They could have required oxygen, but they were excluded if they needed something like high flow therapy or non-invasive ventilation, or of course intubation. So they were excluding the critically ill patient, and they gave therapeutic heparin versus, I think, just prophylaxis when required, kind of thing, like if they required.
Yeah, well, everybody got low dose DVT prophylaxis in the control group.
So the DVT prophylaxis was normal, but then you had therapeutic, and what you found was a significant reduction. Dialysis, whatever. I didn't look at the specifics for which organ support. I just saw I just sort of glazed through the article, but I thought, oh, that's interesting, because I remember hearing the critically ill, like it was a bad idea, because I've been asked even on my Facebook Live, should we be anticoagulating these people? And I said, I think no. Early on I said, we need data to be sure. I said, because I remember hearing, again, case reports of people with bleeds and strokes because of therapeutic anticoagulation. So I said, until we know that the risk outweighs the benefits outweigh the risk, I said, I don't think anybody's doing it outside of a clinical trial, which you guys were doing it within a clinical trial. So yeah, that's actually very exciting, because it's, again, something added to the hospitalized patient pre-ICU that could possibly have a change in outcome. And I saw your tweet saying, we're gonna do it now, or we're starting now, or whatever. So you probably already were aware of some of the data. So you probably had changed practice, but yeah, that's a big one.
Yeah, it's pretty cool. Trials are a lot of fun, actually, a lot of work, but it's great to learn from these patients.
Yeah. Well, I saw the word Bayes in that study, so I'm like, I'm pretty sure Ewan was involved in this. So I'm going to talk about another study published with the Bayes analysis after we talk a little bit more about effort. So Alfred here is asking, is there any role for diaphragm thickening fraction in predicting non-invasive or high flow success or failure? Again, considering the fact that we don't have P0.1, like we don't have the nice, we don't have POC, we don't have these fancy maneuvers. We could drop esophageal balloons in them, but do you think there's a role for thickening fraction, or do you have any data on that?
So this is a brilliant question, and it's a really important study waiting to happen, to be honest with you. I don't have that many patients in my hospital, my emergency room, because it's a mainly referral center. You don't get that much non-invasive ventilation coming through the emergency department. But if people on this show or watching the show work in places where they see tons of patients getting put on non-invasive, then this is a great question to be studying in your center. I think probably the answer would be it would predict. I think if a patient's thickening fraction and effort level don't improve once you put them on non-invasive ventilation, then that's probably a patient is going to fail, whether they're failing just because they're not being effectively ventilated by the NIV, or whether they're failing because the high effort level is actually injuring the lung, or whether they're failing because the high effort level signifies more severe disease. Of course, those are difficult questions to answer. But but I bet it would be an important predictor, but nobody's really looked at it, to be honest.
Yeah. And likely the effect for lung or potential lung issues or lung damage or patient self-inflicted lung injury would be more, I would say, more possible with NIV as well, because you have that additional positive pressure. As we mentioned, you have effort going, you have a strong effort plus the addition of positive pressure. That could be very good. It could be a very useful tool to assess the potential injury, because we know non-invasive ventilation for hypoxemic failure is riddled with issues and high failure rates, et cetera. So that would be an interesting study. So there you go, Alfred. If you see a lot of patients that and you think this would be a possible study, there you go. You've got a fantastic idea.
Reach out to me. I'd be happy to help any way I can. There was a nice paper published recently where people showed that respiratory effort measured by esophageal pressure predicted NIV failure. So, we already have some data to suggest that the respiratory effort level predicts the outcome there.
Yeah.
So
and we know that respiratory
really
rate. Nice. We know that respiratory rate's a horrible predictor.
Yes.
And maybe you can explain some of that mechanism, because I keep telling people that, but I can't always articulate why. I just know that it's not a good predictor. Many studies have looked at respiratory rate alone as a predictor of failure, and when you look at the diagnostic accuracy, the area under the curve is horrible. It's like close to 0.5 most of the time. It's not a very good distinction between failure and non-failure. But maybe you can elaborate on that.
Well, I think it comes back to a question of mechanism. And the point of a ventilator. Like, the point of a ventilator is to unload the respiratory muscles. And so the question is, how well does a respiratory rate tell you about how effectively a ventilator is unloading the respiratory muscles? Routine every day, we assume that if that respiratory rate does tell you something about how effectively a patient's unloaded. And I'm not saying it's completely non-informative, but the truth is that there is a very, very weak correlation between actual effort level and respiratory rate. You can have a high rate and a low effort level. You can have a low rate and a high effort level. And actual true respiratory muscle unloading has to do with effort. So, of course, if a patient's distressed, you put them on the non-invasive ventilator, their rate comes down, they look less distressed, less accessory muscle use, then unquestionably you've unloaded the patient to some extent. But just respiratory rate all by itself can be high because the patient's anxious, because they're delirious, because they're febrile, because they have liver dysfunction. There's just a million reasons why people can be tachypnic, and often has nothing to do with the actual effort level. So, I'm speculating a bit, but I think that's probably why respiratory rate is not a very predictor of how effectively a ventilator is unloading the patient.
Yeah. Yeah. There's been many times, especially since becoming an effort nerd, where someone's breathing, close to 30 breaths per minute, maybe over 30 breaths. And I look at the P0.1, I do a POC, and I said, this patient's not in distress. And they don't look, many of the times, if someone's not actually working hard, they don't, it's very hard to find a patient that is working hard but doesn't look at all like they're working hard. Obviously that's a very subjective view, but typically if someone has, for example, a POC of -30, they probably look like they might have an elevated POC. You might not know it's -30, but they're not going to look like they're asleep and comfortable. They're going to have some element of, and again, you just want to quantify that, right? But usually they're not the sleeping giant. They don't just look like they're super calm. Yeah. Having said that, you could have a very low rate. So go ahead.
Sometimes we have patients with very, very poor mechanics on ECMO, with a compliance of say 10 or 15 mils per centimeter of water, and they'll be generating huge pressures even though they don't look like they're working that hard. And I think it's just because it takes so little volume to generate a huge pressure within such a small lung. So I agree with you most of the time, but I think it's worth monitoring, just because sometimes you'd be surprised.
Yeah. Yeah. And I would agree, even if they look at, you should objectify it, because someone might look like they're working hard, but they're actually not as well. Like it could be the opposite. So it's like whether or not, again, someone could be looking like they're working hard because of anxiety, because of other issues, the same reason the respiratory rate may not reflect effort as well. So yeah, I think it's just something we should always monitor, whether we think it's good or bad. I feel if someone's breathing spontaneously now, when I do my rounds on them, I will check it by default in the morning. And then if I have any, usually I'll check it if I'm going throughout the day, but if I have to do rounds where I don't have to enter the room, if there are COVID-19 patients and nothing has changed, I may not monitor it all the time, but at least once a day I'm checking it during major rounds. And if someone continues on spontaneous breathing and I'm actively trying to wean them, every time I make a change, I'll wait a few minutes and assess again. And I've been pushing that on my platform here for quite a long time in terms of RTs paying more attention to effort, because I feel like we're really trained to look at respiratory rate and get that respiratory rate normal. But what exactly is normal? And I think effort has a lot to do with what should be normal for that patient.
And if you talk to a guy like Dimitris Georgopoulos with PAV, maybe you've seen this, where PAV, for whatever reason, the patient tends to be a bit more tachypnic, but that doesn't mean at all that it's not working as a mode of ventilation.
Yeah, anytime that we've used PAV, I usually preface it to people that if you see the respiratory rate going up, that's okay. We can now monitor things like PMUS using the table that was published by Carteau and Laurent Bouchard, looking at the optimal range of 5 to 10 with PMUS. You could look at their worker breathing bar, which has some limitations, which is why they made that table of PMUS. But either way, you can at least have a better indication of what the patient is doing, because it's a proportional mode. But yeah, most patients will breathe faster, but not necessarily work harder. Yeah. So I want more people to ask some questions. So please, I'm gonna threaten to stop the broadcast unless I see, because it's been 1 hour, and I usually promise my guests that we'll go for an hour. But if there's a couple of questions that pop in the next few minutes, we'll address them. Otherwise, I will let Ewan have the rest of his evening, because as most people that I know in the business right now of saving lives, they're all very busy. And I just want to give a plug to the blog right now while I wait for some questions to come in, where I've highlighted a lot of work by Ewan. I think a few times I've reached out and said, I want to do an article on this and that. So this is, again, not as good as the papers I just shared you, but obviously you can recognize the graphic is from that second paper. And really what this one was just a sort of question and answer. What would you consider key elements to consider for lung protective ventilation? And then a response. And then I have a nice little table here of monitoring options for lung protective ventilation, kind of simplified from the actual paper. What would you consider key elements to consider for diaphragm protection? And again, just another graph here. And then so just a number of questions and responses, and then so common monitoring options for patient effort. Again, just nice and summarized for those who don't even want to read a paper. You can read our blog. Just go check out the blog, coemv.ca. And there's another one here.
Such a great resource.
Yeah, and I have actually a case report that I want to publish from Nutapol actually sent me a case report that they had a patient with really high EDI that they liberated from the ventilator. So I have to put it together in a nice format for the blog, but that should be coming hopefully in the next couple of weeks. And then we did this one again. I like the question and answers with Ewan because I know he's a busy guy. So I'm like, hey, if I send you a bunch of questions, can you just respond and just see how that goes? And then it ends up being published. And this one was interesting because this was a paper looking at diaphragmatic myotrauma definition and importance. And in one of the papers, you did a Bayesian analysis of basically the potential for the diaphragm to play a role, because it's almost like noise in a trial. Like, we don't look at it, but the potential for it being a huge confounder is obvious, really, when you think about it. And I think this has been a limitation of almost every randomized trial, is that this confounder of what is the diaphragm doing that's making everything else look like there's no difference, right? When we think of high versus low PEEP, is diaphragm the confounder? Like, it's highly probable. So that's another one there. And then a couple other ones. I invited Dr. Irene Tellius on. She did P0.1. She gave a little case vignette and then talked about P0.1. There's a whole bunch of pictures on there. And then even looking at, I think I invited Alice for this one. Let me see if her name's down on the bottom. I can't remember her last name. Yes, Alice Grassi. When she was here, I invited her to look at measuring plateau pressure during pressure support ventilation, or even pressure control, but when someone's breathing. And again, some ventilators don't allow you to do this, but this is the Giacomo Bellani, like, this is the whole iceberg thing. And this graphic really represents it well. This is the pressure you think you're delivering to your patient. You do an inspiratory plateau. And again, this patient's inspiratory effort with esophageal pressure, when you occlude the breath, the patient relaxes, and that pressure is then transmitted into the airway pressure because you've occluded the airway, and now you have the iceberg coming to the surface. So this was really the true driving pressure that's being delivered to the patient can be represented here. Unfortunately, not all ventilators allow you to do it, but for the ones that do, it's also another helpful tool, which just to confirm that what you're looking at is excessive effort, really. So let's see if there's any questions. Nope, we just gotta.
I think everybody's tired, Tom.
I think
they've
so.
all been working so hard.
Fair enough. So if anyone has any questions, obviously you can post after this goes live. You can post a comment or a question. I'll try to answer what I can, and anything that I'm unsure of, I will send Ewan a message and I will reply on his behalf. So thank you very much, everybody, for paying attention and watching, and hopefully you'll get a chance to watch it afterwards as well. And I did share most of the papers here. And thank you very much. We got a couple of thank yous.
Yeah, this has really been fabulous, Tom. I just want to thank you for everything you're doing, and
oh, no problem.
And how much fun to just sit and talk about ventilation for an hour. Wow.
Yeah, well, I might just invite you back at some point. And actually, you know what? I think that's what I'll do. Maybe in a little while, I'll get some other guests on here, and I will bring you back I'm just going to give a teaser maybe for this. Maybe I'll bring you back when this paper is actually published. And this is the effect of lowering tidal volume on mortality in ARDS with varies with respiratory system elastance. Again, I saw the word Bayesian there, and maybe we can start off by you explaining what a Bayesian analysis is, because I know I've asked you. I had to present it once. I think I had to present a paper that did a Bayesian analysis, and I'm like, Ewan, can I look at your slides, please? I need to really slowly look this over. But anyways, when this gets published in nice format, sure, we'll have another discussion. You can come on and we'll talk about this paper, because again, for respiratory therapists, I think this is extremely relevant information that we should all be aware of. So thank you very much for stopping by and having a chat, Ewan. If you just want to hold on the line when I end the broadcast, and we'll just have a little debrief. So thank you, everybody, and enjoy your evening and stay safe out there.